For Chapter 9, we'll talk about the physiological transition of the newborn. We'll talk about some labs and tests that newborns have, newborn immediate care, a little bit about jaundice, and then you want to look at ATI chapters 23 to 27 about, nursing care, newborn assessment, any kind of issues with complications, and how you would deal with those. So for a newborn immediate assessment, we're going to do airway, breathing, and circulation, just as we would with any patient. When the baby's born, we're going to make sure that they maintain a patent airway. We're going to suction only if they need it. Per policy, it used to be that they would immediately get suction after birth, but if they take the breath and they're doing okay, there's not necessarily a need to suction an infant. If you do it, you're going to suction the mouth before the nose so they don't aspirate. Breathing begins immediately. There's chemical changes, there's sensory, thermal, and mechanical changes that sort of jumpstart that need or that inherent knowledge of taking a breath when a baby is born. So their circulatory system changes. There was fetal circulation where, mom is providing their oxygen and their nutrients through the placenta, through the umbilical cord, and then they're born and that fetal circulation changes immediately to newborn circulation. So, they're going to get oxygen from their own lungs, they're out of their fluid-filled environment. So it's completely different circulatory system than how they were in utero. So this is stimulated by an onset of respiration. So they start breathing, their circulatory system starts to change. You're going to observe for skin color, ocular cyanosis, which is a blue tinge on the hands and feet, and you're going to check their apical heart rate. Thermoregulation is also very important in newborns. You're going to dry and stimulate, put the newborn skin to skin on your maternal patient if that's okay with her. It's very important to recognize that newborns can lose heat very quickly. They can lose heat by evaporation, by conduction, by convection, and radiation. So newborns have a higher store of brown fat or brown adipose tissue, and it provides heat in the cold stressed newborn. So they can't shiver like a full-grown adult can shiver, so this brown fat offers them a way to be able to maintain their temperature. Newborns are only born with a limited supply of brown adipose tissue, and it doesn't regenerate, so cold stress can rapidly use up this store, leaving no reserve. Several ways that a newborn can lose heat, one being evaporation, conduction, convection, and radiation. So evaporation is the loss of heat that occurs when fluids that cover the body are air dried and converted into vapor. So that's why we dry the infant after birth, because the infant can lose heat through evaporation of the amniotic fluid or other fluids on the skin. So conduction is more so the loss of heat to a cooler surface via direct contact. So you put a warm baby on a cold blanket or on a cold bed, they're going to lose heat through conduction. That's why many times we place the baby skin to skin with mom, so the baby can be placed on a warm surface. That's why you would place a baby on a radiant warmer as well. Convection is the loss of heat from the warm body surface to cooler air currents. So, that's when the baby can lose heat because they're in a cold room. They're losing heat through that exposure to drafts or cool air. So you want to know these ways that you can lose heat. You want to know the differences between them and why we do what we do. Again, putting babies skin to skin really helps with that. Covering their hat, head with a hat really helps with that, and then covering the baby with a warm blanket as well, and making sure that there's not a draft in the room and they're not placed on cool surfaces. And another immediate assessment, so part of that is if the baby is term, so 37 weeks gestation, has good tone, and is breathing or crying per NRP, the baby can be assessed immediately right on the maternal chest. So you can put baby right on mom, you can dry, you can stimulate, you can see how the baby's doing. You can do the rest of the APGARs. Again, if the baby's less than that, if there's no tone or low tone, they're not really breathing or trying to cry, then that's going to be something that's going to be an instance where you take the baby and you take it to the warmer to see if there's a need for resuscitation. So newborns are gonna have continued respiratory and cardiac adaptations in these first few minutes after birth. So breathing begins at birth, their lungs expand, they've taken oxygen for the first time, they're gonna hopefully have a strong and healthy cry. Again, that fetal circulation becomes normal newborn circulation, so the function of that gas exchange transfers from the placenta to the lungs. So they have systemic circulation to pulmonary circulation. Before, there was a foramen ovale, which is a little hole between the atrias that allowed them to just sort of bypass, and because they were already getting oxygenated blood from mom through the placenta, the foramen ovale sort of allowed them to just go from from left atrium to right atrium. That closes soon after birth with the first breath and the clamping of the cord, because now they're going to go from that systemic circulation to pulmonary circulation, just as a normal adult human being does. Another adaptation that they have in utero, called the ductus arteriosus, closes over a period of hours. So that's a little shunt that allowed them to go from the right atrium, sort of bypass the lungs. So the newborns are going to have continued respiratory and cardiac adaptations in these first few minutes after birth. So breathing begins at birth, their lungs expand, they're taking in oxygen for the first time. Hopefully you'll hear that strong and healthy cry. Their fetal circulation becomes normal newborn circulation. So again, what that means is their function of gas exchange transfers. So their function of getting oxygen and releasing carbon dioxide transfers from the placenta and mom to their own lungs. So that systemic circulation transfers to pulmonary circulation. So the foramen ovale, which is a small opening located between the right and left atrium of the heart, that typically closes soon after birth with that first breath. So what happens in utero is it allows oxygen-rich blood from the placenta to bypass the fetal lungs, because they don't need to get oxygen from the lungs. They already have it from mom. So it goes right from the right atrium into the left atrium. It's essential when the fetus is in utero, because the fetus receives oxygen through the mother's blood rather than through its lungs. Again, it's receiving that oxygenated blood through the placenta. So it's a little shunt in utero that is typically supposed to close soon after birth, because now they're getting their oxygenated, now they're getting oxygen from their own lungs, just as we do. The ductus arteriosus closes over a period of hours, and if this doesn't close, it's called a PDA, or patent ductus arteriosus, and you might hear a continuous murmur. So the ductus arteriosus is vital in utero because it connects the pulmonary artery to the aorta, again allowing that oxygenated blood to bypass the lungs, because they don't need to get oxygen from the lungs in utero, because mom is already providing it through the placenta. So what this looks like is a baby, takes a few minutes to sort of transition from intrauterine life to extrauterine life. So what we're going to do in our immediate assessment is do an APGAR score at 1 minute and an APGAR score at 5 minutes. APGAR, in recent years, people have used it as an acronym for appearance, pulse, grimace, activity, and respirations. It's actually a last name of a woman, Virginia APGAR, that first used it. She was a doctor. But you can use it, as the acronym, because it will help you to remember what you're assessing. So, if you had a baby that, came out, wasn't breathing, didn't have a pulse, didn't have any activity, didn't have any respirations, this was totally blue, you're not going to wait 1 minute to treat that baby. You're going to cut that cord and take that baby over to the warmer and start neonatal resuscitation. But in a baby that's term, in a baby that has good tone, in a baby that's having some effort, with breathing and with crying, you're going to give them a score at 1 and 5 minutes. So how you do that is you're looking at their appearance, you're taking their pulse, you're looking at their grimace or reflex, you're looking at their activity, and you're seeing about if they're having respirations and what those respirations are like. So for appearance, completely pale, completely blue, no pulse, no response to stimulation, there's no activity, they're totally flaccid, no tone, and they have no respiratory effort, that's going to be 0. So that's a baby that needs to be resuscitated. You're going to take that baby, cut the cord, take it to the warmer, and start neonatal resuscitation. They get points if they have any sort of, so basically 0 is, baby needs resuscitation immediately. 10 is you have a completely perfused pink baby, they have a pulse that's more than 100 beats per minute, a strong cry, you rub their feet or dry and stimulate them, they sneeze, they cry, they have a reaction, their arms are well flexed and their legs are flexed, they are actively moving, a vigorous cry showing good respirations, that baby's going to have 2 points for each of those things. So 10 is wonderful, great, transitions going beautifully. 0 is you have a baby that needs to be immediately resuscitated. Anything in the middle of that, they get points taken off. So if they have blue extremities, which we call acrocyanosis, but their body is pink, so that's perfused, their face, their trunk, that's perfused, that's normal, they do get a point taken off. If they have respiration, if they have a pulse less than 100, you're listening to you're listening apically and you're counting less than 100, they'll get a point. If you try and stimulate them and they just grimace or they have a weak or slow response, they're getting a point. If they have some flexion of their arms and legs, they're getting a point. And if they have a weak, slow, or irregular cry, they're still trying, so they're getting a point. So you're just looking at all of these things and grading them depending on what you see. So because of that fetal circulation and newborn circulation, it doesn't happen immediately. It does take them a few minutes, sometimes even a few days, for those shunts to sort of go away and for them to, transition to extrauterine life. Acrocyanosis, which is, the blue hands and blue feet, that's a normal finding because they're really concentrating on perfusing, those main organs that they need to perfuse, and their body will eventually get to the extremities. So even though they're losing a point in their APGAR scores for a very new baby, less than 24 or 48 hours, acrocyanosis is a normal finding. So that's something that you want to know. So for newborn immediate care, you're going to be checking the umbilical cord, you're going to be identifying your baby, taking vital signs, doing measurements, giving medications. So the cord will be clamped and cut. And we've spoken before about delayed cord clamping, so sometimes they'll wait until the cord is white, until it stops pulsing. That gives baby sort of a little blood transfusion of its own placental blood. So they'll wait for that cord to stop pulsing, they'll clamp it, they'll cut it. What you're looking for is that there's 3 vessels, so 2 arteries and 1 vein. You're going to leave this open to air. Before they would say, you can alcohol it, or, you need to cover it up. You don't need to do that now. That cord can be left open to air. It'll eventually fall off after it's clamped, in about a week or so. You're going to do vital signs in the infant per policy. Most of the time it's Q30 minutes for the first 2 hours, but again, that's going to depend on where you're working. The measurements are done and then medications are administered after skin to skin per policy. So, a lot of hospitals now will have skin to skin for the first 2 or 3 hours to help with breastfeeding, to help with temperature regulation. And then after that skin to skin or first 2 hours is done, you can get your baby's measurements, you can administer their medications. Immediately, though, you are identifying them. So putting their bracelets on, identifying them as the patient that belongs with the mother, belongs with the partner. So usually, I'll show you, we have a bracelet set, comes in 4s. So mom will get one, partner will get one, baby will get one on their arm, and baby will get one on their leg. But that, again, is per policy. So we want to identify them, even in the operating room, before they leave that operating room, you want to identify them because that's the way that we know, okay, that infant goes with that mom. So mom's going to have one, again, the significant other's going to have one, the infant's going to have 2, one on the wrist and one on the ankle. In admission in the labor room, the mother is usually fingerprinted with her right or left index finger, so let's see that right here, and then baby's footprints will go on this sheet. This is the sheet that the patient, the mother, will sign at discharge, and basically this says, yep, this is my baby, this is the baby I've had the whole time, this matches the number on my bracelet. They do that for safety and for identification reasons. And again, it'll change per policy and per hospital, but you might see something that looks like that on admission, and then you might see it again if you're in charge of discharging both mom and baby. So immediate care, you're going to assess vital signs again per policy. Most of the time it's Q30 times 2 hours, then Q1 hour, and then normally for the first 24 hours you're assessing babies Q4, sometimes Q8, depends on the policy and depends on if there were any complications. The normal temperature for an infant's anywhere from 97.7 to 99.2 Fahrenheit. Pulse, you're going to assess the apical pulse for 1 full minute because it can be irregular. And again, just like when we were doing fetal heart tones when mom was still pregnant, you want those you want that apical pulse to be about 110 to 160. It can be lower in deep sleep, it can be higher when baby is vigorously moving or crying, but that's in general your normals for fetal heart rate. Respirations, again, you're going to count them for a full minute. They can be irregular. Anywhere from 30 to 60 is normal. They do periodic breathing. Sometimes they'll take a break for 5 or 10 seconds. You want to auscultate and you want to observe for 1 full minute because of that irregular breathing. And again, you're looking at their chest. You're making sure, there's 2 nipples. You're making sure that they have no work of breathing. You're making sure that the sides are equal when you're comparing them to each other. Most of the time they'll have a pulse ox on for the first 2 hours or so, and then a blood pressure is taken with an automated machine. Most of the time with healthy babies, that blood pressure maybe is taken once at birth. It would obviously be more if there were issues or baby was in the NICU or had some sort of higher level of care. In general, newborns weigh about 2,500 to 4,000 grams. These are averages. So, you've seen babies smaller than this, you've seen babies bigger than this. Anything smaller than the 10th percentile, so, if we have a percentile, like an algorithm for male babies, an algorithm for female babies, anything less than the 10th percentile is considered SGA, or small for gestational age, comparing their gender to how many weeks they are. 39 weeks female, there's a specific algorithm that you're looking at, or a specific chart that you're looking at. Anything greater than the 10th percentile, so in the 90th, or anything greater than the 90th percentile, is considered large for gestational age. So again, there's a specific chart for, male and female babies compared to how many weeks they are. And these babies, the smaller ones and the bigger ones, are at higher risk for hypoglycemia and issues with maintaining their temperature and glucose. So you want to just be aware of that. Usually infants lose about 5 to 10% of their weight. That's normal. It might be different with formula feeding babies, but with breastfeeding babies, they lose a lot of water. Colostrum is made up of water and antibodies, and they're not really gaining weight until that day 3 or day 4 when that full milk is coming in. Average lengths are 48 to 53 centimeters, which is 19 to 21 inches. 33 to 35.5 centimeters, which is 13 to 14 inches, and their chest measures about 30.5 to 33, which is 12 to 13 inches. So usually the chest is about an inch or so smaller than the head circumference. So there's 3 newborn medications that you'll need to know for this course. Vitamin K, which is phytonadione, a synthetic vitamin K, hepatitis B vaccine is offered, and then also erythromycin. So phytonadione, which is how you'll see it, on any type of exam, you're always looking at the generic name for medicines. It's a synthetic vitamin K. It helps the small intestine to make blood clotting factors, and because newborns have a sterile gut, they need that bacteria to synthesize vitamin K, and they don't have it. So we give it to them in a shot. It supports their blood clotting, it's given IM, and their vastus lateralis muscle. Usually that's 1 milligram and 0.5 ml, and that's the neonatal concentration. You want to know everything that there is to know about the newborn meds, because there's only 3 of them that we're going to be learning. So phytonadione, which is vitamin K, it's used to help the small intestine make blood clotting factors. Newborns' guts are sterile, so they don't have them on their own until about 6 months of age. It's given IM in the vastus lateralis muscle. Normally they'll give one shot in the right leg, and then they'll give another in the left leg. So if you get vitamin K in your right leg, baby will get hepatitis B in their left leg. That just depends on the policy. So erythromycin is an ophthalmic ointment. It's applied to both eyes, and that helps prevent ophthalmia neonatorium, so it's an eye infection within the first 30 days of life. It can be caused during birth by contact with the birth canal of a mom who has an STI, such as gonorrhea or chlamydia. It can delay, or you may delay it to promote eye-to-eye bonding. You want to observe for the red reflex before applying. So you'll have a provider observe for that red reflex. If there's any issues with that, if it's white, if it's cloudy, that may be delayed. But that's going to be per provider. So what you're going to do when you do that is you're going to make sure you're not touching the eye. You're going to go from the inside of the eye to the outside with just like a small ribbon, sort of pushing that out, just like a Vaseline or something. You want to make sure that that tip doesn't touch infant's eye, and you want to make sure that the eyes are open when you do it and that you get both eyes equally. And again, you'll have orders for these medications. You need to know why we are giving them, where we are giving them, how we are giving them, because there's only 3 that we need to know for this class. So the hepatitis B vaccine is offered to parents. Parents are given a vaccine information sheet. You do need to get consent, and usually that's administered within the first 24 hours after birth. Again, if you get vitamin K in your left leg, maybe you'll get hepatitis B in your right leg. In the right vastus lateralis muscle. So you want to educate people to complete the vaccine series. So you get one at birth, you get one at 1 month, you get one at 16 to 18 months of age. There are exemptions. You know, a lot of people, maybe they'll have issues, or they'll challenge getting hepatitis B vaccine in the hospital, and you just want to educate that it's offered. They can get it with the pediatrician, you know, when they go. They cannot get it in our state. There are medical exemptions and religious exemptions for hepatitis B vaccine and other vaccines. There's not philosophical exemptions. So in some states, you know, depending on where you are in our country, you can just say, I philosophically just don't agree with this. In our state, you have to have a medical reason or a religious reason to be exempt, and then it's up to wherever you send your child to school to accept that child if they have not gotten a hepatitis B vaccine. Your job as the nurse is just to educate the parents on that it's offered, that there's a complete series. You get one again at 1 month, one at 16 to 18 months, and that most schools and daycares do require it. But again, in our state, there are medical and religious exemptions, and then that's just a conversation that you would have with the school that you choose, and or the daycare provider that you choose. So your job as a nurse, give them the information sheet, offer them, tell them about the complete vaccine series, and then, you know, if they refuse, then you chart that you gave them the education, you chart that they refuse, and that's up to them to deal with that whenever their child is school age, or whenever their child needs to go to a place that requires vaccinations. So newborn care for behavioral patterns, there's a first period of reactivity and a second period of reactivity. And it's not like you need to memorize these. It's just sort of so you know what is expected. So birth to 30 minutes, lots of times you'll see the baby's very alert. There's a lot of movement. They may appear hungry and be looking for the breast or trying to find the nipple. From about 30 minutes to 2 hours, there's a period of sleep or decreased activity. And then they get a second wind, basically, when they're between 2 and 8 hours old. The newborn sort of awakes and shows interest. Again, lots of times that second night, the infant sort of realizes, oh, I'm hungry, and I want to eat, and I want to, you know, see what's happening. Mom's exhausted, support person's exhausted, baby's up all night. That's normal. You want to educate them, you know, the more often you can put the baby to breast, or the more often you can, sort of have baby skin to skin, the faster you'll sort of get a routine. Nursing care for nursing students and nurses in women's health, you're going to educate parents to meet the infant's needs. So, you want to keep a regular feeding schedule. Breastfeeding is on demand, but in the beginning we try to say, like, don't really let them go more than 2 or 3 hours, because they really need to teach your body to make that colostrum. They need to practice. The more the baby sucks, the more the baby gets on, the faster the milk will come in, and the better off feeding will go. So, you want to educate them on breastfeeding or bottle feeding, keeping the baby dry and comfortable, holding them skin to skin to promote trust, to keep them warm, to keep their temperature regulated. You want to offer kangaroo care, which is skin to skin. Swaddling is comforting and promotes sleep for babies. A lot of breastfeeding or lactation consultants will say to keep the arms out of swaddling so they can move, suck on their fists, or self-comfort. Some babies really like to be tightly swaddled. It just depends on your baby. And you want to educate women and partners. It just depends on, their choice, how they want to do it, how comfortable is the baby, what keeps the baby, feeling safe and warm. And then also sort of like you want to have like an in-between, so if baby is showing you signs of hunger or showing you signs of, needing to suck, they do have their hands available so they can put it towards their face, or they can sort of comfort themselves. Newborn bathing, you're going to bathe the baby given per policy. So we used to bathe them immediately, at birth, within 2 hours or so. It is shown if you wait that there is, it can help with breastfeeding, it can help with bonding, it can help with temperature regulation. So there's no real reason to give an immediate bath. If the mother is HIV positive, hepatitis C positive, normally policies will have an immediate bath, or if the baby has, if the mom wants an immediate bath, you can do that, but that again is per policy. So when you do give it, you're going to wear gloves. We're not going to put lotions or powders on the baby. You're going to bathe their face first with a wet washcloth, no soap, and then with soap you're going to do their chest, their upper extremities, abdomen, lower extremities, their back, and their bottom. So after the bottom, you're going to get a new washcloth. Wash anything they haven't done yet, any extremities or anything else. Wrap the infant up, and then you're going to bathe the head last, because again, they can lose their heat fast. So you want to have them warm, and you can do it under a warmer as well, but if you're not doing it under a warmer, I would wrap the infant and bathe their head last. So you're going to do and educate parents on a sponge bath until the cord falls off and the base is dry. That umbilicus could be a portal for infection otherwise. So basically, you're going to put them in a little basin, or you're going to have them on the warmer and just do a little sponge bath. And then once that cord falls off at 7 to 10 days, you could put them in a little baby bath, but they can actually be submerged once that umbilical wound is healed. So you're going to demonstrate this to parents, and you're going to educate them on, keeping the temperature of the water at a safe level, not leaving the baby standing right there. A lot of it is just about safety, keeping the baby warm, keeping the baby comfortable while you're doing it. Discharge instructions are going to begin upon admission. So as soon as mom gets in, as soon as your maternal patient comes to labor and delivery, you're going to educate her on basic infant care. A lot of people have never been around a baby, have never had a baby before. You're going to see, are you breastfeeding, or do you plan to formula feed? How can I help you with each of those? You're going to talk about safety measures. So safe sleep, putting the baby on the back to sleep, not having any blankets, not having any toys in the bassinet or crib. You're going to educate her and her partner on immunizations, to schedule for that. Again, the hepatitis B, that's offered right in the hospital. Vitamin K is not an immunization, but it is offered to help newborns, to help with those clotting factors. We want to educate people on, the whys of why we're offering that. Most of the time for returning, they'll be seen within a day or two. I'm going to educate them on admission of that. So if you get discharged on a Tuesday, lots of times newborns will get their appointment with a pediatrician on Wednesday or Thursday. You want to educate them on using a car seat safely, and then educate them on calling for any signs, any problems, any illness, fever. Most of the time you'll get a discharge sheet that you can give to parents that says, these are reasons you would call immediately, these are reasons you can call your doctor, these are the normals, these are the abnormals, these are things you need to call about right away. So for the newborn assessment, the head to toe, you're going to, most of the time we do this, we do a quick assessment right away. We're sort of, making sure everything's there, making sure everything is, where it's supposed to be. In the first few hours, you're going to do a full newborn head to toe assessment, and you're going to note their general appearance. So how alert are they? What's their resting posture? How's their cry sound? Their quality of their muscle tone, their motor activity. And again, this is different than that APGAR, where you're really just looking at their appearance, their color, are they crying? Are they breathing? This is more so their general sort of head to toe assessment. And then you're going to do a neurological assessment assessing their reflexes. So this right here is the rooting reflex. So if you put your finger to the side of their mouth, do they move towards your finger? Or, do they turn their head towards the object? Suck is, there's not a glove on this finger, but if you were a nurse, you would have a glove on, you would insert your pinky or small finger in their mouth and see if they suck. So that shows you, yes, they have that neurological, that sort of innate sucking reflex. This is helpful to do also because you can feel if their palate is closed, because you can have a cleft palate and not a cleft lip. So your lips can look perfect, and then your palate can have a cleft or hole. So you want to assess that, make sure that that's intact, make sure that it's closed. And also sometimes when babies have a higher palate, that can pose issues with breastfeeding or feeding. So it's just important for you to assess what's going on internally. The Moro or the startle reflex is when you have a baby and you perform a bit like a hand clap or something loud, and they sort of put their arms up like this. That's called the startle or Moro reflex. And then this tonic neck or fencing reflex, we're not doing anything to make it happen or elicit it. You're just sort of putting a baby on its head, on its back, and they're sort of turning their head towards their long extended arm. So that's just called the tonic or fencing reflex. Again, you want to see these reflexes. It's showing you, neurologically the baby is doing okay, doing what it should do. And then a lot of these, they lose within the first year or so. Obviously sucking, that continues, but, immediately, rooting, sucking, this Moro reflex, this tonic neck, these are reflexes that human infants come with and you should see. That will give you a good idea that they're doing okay neurologically. So there's more reflexes that you need to know. The palmar grasp is, you're putting your finger into the baby's palm and they grasp it. The plantar grasp is you're putting your finger into the bottom of their foot and they're grasping that as well. Stepping is you take a newborn and you hold them up, you support their head, and they immediately put one foot in front of the other. That's called the stepping reflex. That's normal and it's expected. And then the Babinski reflex, if you were to put a 7 or a J, on the bottom of this foot right here, the toes flail out. So that's normal in a newborn, and that's called the Babinski reflex. So palmar grasp reflex, plantar grasp reflex, Babinski reflex, and stepping reflex are just continuations of that neurological assessment. Continuing the newborn head-to-toe assessment, you're going to assess their head. 2 variations of a normal, so molding is normal because these sutures aren't ossified in utero. They mold to help a human baby navigate that birth canal. So you might see molding, and that is normal to see. It's important for you to know if you do a head circumference, at birth, that it might be a little bit different the next day as this sort of, evens out and gets more rounded. It's also important for parents to know that this is normal and that it does go away. So normal because the sutures are not ossified in human babies. They are moldable and pliable so a human baby can navigate the birth canal. Caput is something you should know about, and cephalohematoma is something you should know about, and you should know the difference between the two. So caput is just edema or fluid that crosses the suture lines. A lot of babies will have that postpartum because of that fluid or because of that edema from birth. A cephalohematoma doesn't cross the suture lines, and that's more a collection of blood, sort of like a hematoma or a bruise, and that can come from, being misaligned or having having a long delivery where their head is sort of in a way where blood can. Newborn assessment head to toe continued. You want to know what's normal when you're looking at your infant. So a lot of babies will have molding, which is something that you see commonly because these sutures and these bones of the skull, they're pliable. They don't ossify for the first year or so of life. So they're pliable so the human baby can navigate the birth canal. So this molding that you see after birth is very common. It's important for you to know as a nurse, if you do head circumference on this baby on Monday, it might be a little bit less on Tuesday because that kind of rounds out, which is expected. You also want to educate the parents that it's not permanent and that it is something that has to happen so the baby can be born vaginally. So 2 things that you might see also are caput and cephalohematoma. So caput is just a collection of fluid or edema that can often come from the labor process that crosses the sutures. So you can think of it as like a cap. It covers the whole head. Caput, like cap, it covers the whole head. You'll want to know the difference between these two. A cephalohematoma is more like a bruise or a hematoma. It's a collection of blood. Sometimes it can be because of an infant or fetus, the way they are in utero, sort of hitting the pelvic bone while they're navigating the birth canal. That doesn't cross the sutures, and usually that won't even manifest for a few days after birth, and then that takes a few weeks to settle down and go away. So you want to educate parents, this is something that it might take a little while to heal. Caput, usually that's gone in the first few days. So caput crosses the suture lines. Cephalohematoma does not cross the suture lines. This is fluid, this is blood. And then the fontanelles, when you're assessing those fontanelles, this is that anterior or front fontanelle. That doesn't close for about 18 months to 2 years, again, because these bones of the skull are not ossified. They need to be pliable or soft so the human baby can be born. And then this posterior fontanelle, you can feel it's a little smaller. It's more of a diamond shape. That closes in about 2 to 3 months. And that's going to be part of your assessment. So fontanelles can be depressed if an infant is dehydrated. They can be bulging, which could mean intracranial pressure. So what you want to feel is just small indentation, but you don't want them to be depressed. You don't want them to be bulging. That's something that you would contact the provider for. So again, how you're going to measure is you're going to measure the head circumference above the ear and above the eyebrow, and in general it's about 32 to 37 centimeters in circumference, or 12.5 to 14.5 inches. For the newborn's face assessment, you're going to make sure that their eyes and ears are symmetrical, that there's 2 of them, the mouth is symmetrical, the mucous membranes are pink and moist, they have a strong suck reflex. Most of the time when you're looking at the ears, if you can imagine sort of a line from the outer canthus of the eye to the top of the ear, sometimes ears can be low set and that can just be genetic. Sometimes it can be indicative of a syndrome, so that's something that you're assessing and you're looking at when you're looking at a newborn's face. You're looking at that outer canthus of the eye, and does it match up with the top of the ear. Infants can approximately see about 6 to 12 inches. They prefer human faces. They can sometimes appear cross-eyed. They will turn to follow an object, and again that red reflex is examined at birth. They can basically see red, black, and white combinations immediately after birth, and then eventually they can start to see color. A lot of Caucasian or fairer babies, their eyes seem to be like a navy or sort of murky blue color, and then they'll even out to be green, blue, or brown. Some really light eyes, some really light blue eyes. The babies are born like that, with the eyes as light as they are. Some darker skinned babies or darker eyed babies, they're dark from the beginning. So they don't necessarily get lighter, but sometimes they'll change in hue. A lot of times with Caucasian babies, again, it's sort of like a navy blue color, and then they even out and they become green, brown, or blue. With darker skin, darker eyes babies, most of the time their color, their dark eyes that they have at birth, they continue to be dark-eyed babies throughout their infancy and childhood. And then again, once in a while, we'll see, babies with bright blue or bright green, and they kind of come like that from birth. Variations of a newborn's face assessment are, you can sometimes see Epstein pearls, these little white sort of variations of a normal newborn assessment in their face. You might see Epstein pearls on an infant, and those are just harmless white or yellow bumps that appear in the baby's mouth. You might see thrush, cleft palate, again, so this is a baby that has a cleft palate because of that opening. From the outside, lips look perfect, so that's why you always want to assess that. Sometimes infants will be born with cleft lip and cleft palate. Again, that's something that can be seen on an ultrasound, but it doesn't always happen. Sometimes that can be a surprise. Some infants are born with teeth. They're considered natal teeth. Infants can have a lingual frenulum, so a lip tie, which sometimes makes breastfeeding a little bit more difficult. Not necessarily. They can also have tongue ties. It depends on the provider and how they're eating, how they would treat that. Babies can have ear tags. They can have vaginal tags. So these are just variations that you would note in your assessment and that you would contact the provider to let them know about, but not necessarily harmful. Except, in cleft palate and cleft lip and tongue tie and lip tie if they're having issues with eating. Newborn assessment hearing. You're going to have increased responses to vocal stimulation. Infants prefer high-pitched voices. They can discriminate mom's voice. They can tell mom when she's talking. So there's Universal Newborn Hearing Screen Test. It's part of newborn assessment, newborn testing that babies get in our country. The top photo is called otoacoustic emissions test. The bottom photo is auditory brainstem response test. So that auditory nerve is speaking to the brain, sending signals, yes, I'm hearing these high-pitched sounds. These are very similar to the tests that you see younger children or toddlers get in elementary school, but because the infant can't tell you, yes, I hear it, it just comes out on a computer printout of, each ear. Did the ear pass? Did the ear refer? And depending on the policy, you would do the test again in 6 to 12 hours. Most of the time, even if an infant refers or doesn't pass, it doesn't necessarily mean there's hearing loss. It just means that they would get an auditory referral so they can be checked up on. A lot of times with fluid, or if they've just had a bath or something, that can interfere. Sucking can interfere. Outside noise can interfere. So you want to educate parents. It doesn't necessarily mean they have hearing loss. It just means that you're going to be referred and you're going to follow up just for more information. For the newborn chest assessment, again, it's about 32 centimeters. It's approximately a centimeter or two less than the head. You can see there's xiphoid cartilage. You might see engorged breasts. You want to observe the infant at rest. A lot of times when you walk in the room, doing that chest assessment and doing that assessment of respirations is very easy if they're quiet and they're just kind of in an alert stage. So you're observing the shape of the chest. You're observing, both sides. Are they rising symmetrically? Is the baby having any work of breathing? You're assessing nipples for size, for placement. You're assessing their respiratory effort, and then also you're assessing their heart sounds. So for the newborn assessment of extremities in the back and variations, so here, right here we have syndactyly, which is webbed fingers, polydactyly, so we have an extra digit here, A single palmar crease, sometimes that can be indicative of syndrome, sometimes people just have it. So this is a normal palm crease where you have two of them. Sometimes there's a single crease above, across. That's just something that you're investigating. For the back and rectum, you're making sure that their spine is straight, that you're looking for no dimple or tuft of hair, and that they have a patent anus. Years ago, that would be done with a thermometer, but now, because of the risk of bowel perforation, you're just making sure that they have those first meconium poops in the first few days of life, which normally happens very quickly in the first day or so. If there is a tuft of hair or something, they would possibly investigate, do an ultrasound, see what's happening. It can be a sign of spina bifida. Sometimes these small little dimples just close up. It depends on the provider how they would care for that. And you also want to, be aware of, do you have parents that are genetically, have a lot of hair? Is it just hair? So it's something that you would mention to the provider, something that you would show them, not necessarily something bad, but it could possibly mean some issue with the spine. So it's just a variation of normal and something that you would pass on. For the newborn integumentary assessment, there are things that babies can have. So they can have lanugo, they can have its fine sort of downy hair. Vernix caseosa is that slippery sort of white cheesy substance. It protects them from the amniotic fluid in utero, helps them to guide themselves out the vaginal canal, so it helps with birthing. Milia are small little sebaceous sweat glands on their nose. Normal, they usually subside. Some babies have stork bites. Mongolian spots are now called congenital dermal melanocytosis. So that's just, I'll show you on the next slide what they look like. Acrocyanosis again is normal, that blue color of the hands and feet. Erythema toxicum is newborn rash. Mottling, harlequin sign, and nevus phlemeus or port wine stain. So this is that lanugo, that fine downy hair. Preemie babies have it more. Sometimes babies just have it, if again they're genetically more hairy. But that fine sort of downy hair, they lose in the later weeks. So a lot of times babies that are born prematurely will have this, and they'll have it all over their body. Again, it's protecting them in utero. This is the vernix, this cheesy substance. Again, you'll see this more so in babies that are earlier, and that helps provide protection from the amniotic fluid in utero, and it helps for a slippery birth, so it gives some lubrication out the vaginal canal. This is the milia. Normal, goes away in a few weeks, just little sebaceous sweat glands, look like little teeny pimples. It's a normal finding. This is the stork bite. These are the Mongolian spots. It's a little bit hard to see. Usually you can see them on Eastern European, Hispanic, African, darker skinned babies. They can be anywhere, but a lot of times they're on the sacrum. And again, they're just sort of pockets of extra melanocytes or extra, the cells that give your skin color. They're just sort of pockets of extra ones. You do want to make sure that you're charting that these exist, because they can look like bruises. So if a baby has that congenital melanocytosis, that means they're born with it. You want to make sure that that's charted, so that no one is thinking that they're bruises. And again, lots of times on the sacrum, but they can be anywhere on an infant, and they usually fade with time. This little baby, again, he's hard to see, but he has acrocyanosis. So good perfusion in the lungs, in the heart, in the main organs. Face is perfused, brain is perfused, but the extremities are bluish. So that's normal in the first day or so, and that's called acrocyanosis. So pink body, blue hands and feet. This is the newborn rash, the erythema toxicum. It's transient. Usually it moves. You might find it on their face. Next time you walk in the, room, you're going to see it on their chest. Mottling can be seen because of an immature central nervous system. Babies that have issues with their central nervous system because of withdrawal also have mottling, so you might see that in babies that were exposed to opiates in utero, but it is a normalish finding. Harlequin sign is just a transient discoloration, so sometimes if a baby leans on one side and all the blood pools, it's harder to tell in this picture, but this little baby's face is kind of red on his right side and more skin toned on the left, and that's transient. And this is an example of the port wine stain, which is permanent and might grow with age, but it is something that you want to note on an assessment because it is a variation of a typical newborn. So to check your knowledge, you're providing care to a 1-hour-old newborn who was born at 39 weeks gestation. Which assessment data is cause for concern? So 1-hour-old full-term baby. So respiratory rate of 82 breaths per minute. I would hope that you would recognize, in a non-crying baby, that's a little high. So 30 to 60 is normal. Negative Babinski reflex, that's something we want to investigate. These babies are born with certain reflexes, the Babinski being one of them. Mean blood pressure of 52 is fine. Acrocyanosis is fine. Presence of a soft heart murmur. So at 1 hour old, because those adaptations are still changing, that baby's still going from fetal circulation to newborn circulation, you might hear a soft heart murmur, so that's okay. Not necessarily something that you need to investigate. If it continues, you would want to call the provider and you would want to maybe look into it. But at 1 hour old, it's not necessarily something not expected to hear a soft heart murmur. So respiratory rate of 82 breaths per minute, too high, negative Babinski effect, reflex. So you might encounter some newborn labs and tests in labor and delivery and women's health. Usually labs are done when an infant is at least 24 hours old and has fed. When we're talking the 24-hour testing, you're looking for inborn errors of metabolism. So PKU, hypothyroidism, galactosemia, any kind of issues with metabolizing formula or breast milk. That's what they're testing. They're testing for about 40 other conditions in our state. You can check the link to see what they're looking for: cystic fibrosis, sickle cell anemia. And this is just a public health initiative, so babies that are born with issues that can be resolved or can have some sort of treatment are getting the treatment that they need. In the end, it costs less and newborns have a better outcome the earlier that issues are identified. So part of your 24-hour screening, if you hear that in clinical, is they're looking for this, they're taking a little bit of blood, they're sending it out to the state. Also, the hearing screen will be part of that newborn screen. So when we perform these tests, we're going to warm up the infant's heel. There's actual heel warmers that are made for this. You're going to use alcohol, you're going to wipe, you're going to have gloves on, you're going to use a baby lancet to get a little spot of blood from the inner or outer heel, not right in the middle where there's a little nerve in there, and you're going to try to get 5 little circles of blood, and you really try very hard to get exactly what they need, not any less and not any extra, because they will send it back. So you want to explain to the parents, this is a public health initiative, it's mandatory in our state, we're just checking for any issues that could cause them issues in the future so that you can know them and identify them and get the help that you need earlier rather than later. So other newborn labs and tests you might see are testing the cord blood. So on any mom or any maternal patient that's type O, and any maternal patient that's an Rh blood type, an Rh negative blood type, they're going to have a direct Coombs test, which is they're going to test the baby's cord blood, see if there's any antibodies that have already sort of coated baby's red blood cells. That will let you know that that baby is at a higher risk for jaundice and hyperbilirubinemia. Blood glucose. So normally babies don't get their glucose checked unless they're high risk or symptomatic. That is also done as a heel stick. So you would check their glucose if they were small for gestational age or large for gestational age, if they're pre or post term, infants of diabetics. And all of this is because these are babies that are at higher risk for hypoglycemia. So they lose that glucose source at birth. The placenta's cut, the umbilical cord's cut. These babies are at higher risk of not being able to maintain their glucose. Babies that are small, babies that are big, babies that are pre or post term, and then infants of diabetics. Whether she's type 2 or gestational diabetic, these infants have a higher risk of hypoglycemia after birth, so they're going to be put on a blood sugar protocol. If glucose is less than 45, You're going to feed the baby, so either breastfeed or supplement. And again, you will have a blood sugar or blood glucose protocol policy that you're following, and you'll have, individual numbers that you're looking at depending on the hospital that you're working in. Newborn screening, again, it's mandated by law. That's a heel stick. You're going to send that out for results. The parents get that in a few weeks. If there's any issues, the state would call them. And then transcutaneous bilirubin and serum bilirubin. The transcutaneous bilirubin is an external exam that they get with a transcutaneous bilimeter, and that is giving nurses an idea of the baby's bilirubin levels. And as the infant ages, so as they get older, bilirubin levels do rise. Bilirubin is just a byproduct of broken down red blood cells. They break down red blood cells faster than older adults, and because they break down red blood cells faster than older adults, and because they can't quite conjugate bilirubin as an adult can, bilirubin can there can be a buildup of bilirubin in the blood, and bilirubin is a neurotoxin, can cross the blood-brain barrier and cause permanent damage. So we're checking this. Now how they do it is you do the transcutaneous every 8 hours. So you might do it at 8 a.m., you might do it at 8 p.m. You're seeing how fast the levels are rising compared to how old the baby is. If you needed a serum bilirubin, so if you needed a total bilirubin and you needed to actually check the blood, you're going to do that again with the heel stick, and we'll learn about how to do that in clinical. So these are just some of the things that they're looking at when they're doing those newborn screens. They're looking for PKU, which is a rare disorder that prevents the body from properly breaking down the protein, phenylalanine. So newborn labs and tests, these are just some of the things they're looking for. They're looking for PKU, galactosemia, congenital hypothyroidism. Again, these are things, if you can identify early on, they can figure out, how they're going to deal with feeding the baby, how they're going to deal with metabolizing, how they're going to deal, Newborn labs and tests are also going to be what they're looking for the 24-hour labs. PKU, galactosemia, they're just examples of what the state is looking for. Again, they're looking for cystic fibrosis, sickle cell anemia, about 40 to 45 different conditions, again, as a public health initiative that each state in our country mandates. So again, the transcutaneous bilirubin is done 12 hours apart. You would do blood per policy, and how you get that blood on the infant is a heel stick. So part of assessing for hyperbilirubinemia is one of the most common newborn problems. Hyperbilirubinemia just meaning a lot of bilirubin built up in the blood. So a lot of bilirubin in the blood, hyperbilirubinemia. So the neonatal liver is immature and it undergoes several changes in function during the early postnatal period. And in general, newborns are producing more bilirubin than adults. They have a greater production and faster breakdown of red blood cells in the first few days of life. And bilirubin is just that byproduct of those broken down red blood cells. So at 2 weeks, the liver is more effective at processing bilirubin, and jaundice often corrects itself by this age without causing harm. About 50 to 80% of newborns get jaundice. They don't all need to be treated. Premature babies, because they have an even more premature liver, are more at risk, and also babies that have bruising, because those red blood cells are going to be breaking down, and because they're already breaking down blood cells faster than adults, any kind of bruising, any kind of prematurity, those babies are at higher risk of bilirubinemia, which manifests as jaundice. Jaundice being that sort of yellow coloring of a baby's skin, of their sclera. And again, it's an issue because bilirubin is a neurotoxin, can cross the blood-brain barrier, and can cause permanent damage. So why we're assessing for this is we want to know, are the levels rising high enough that we need to treat it with phototherapy? Is it something that we need to watch? It just depends on, how fast the levels are rising, what your baby looks like, how your treatment would be. But assessing all infants with a transcutaneous bilirubin is part of hospital policy. Recently, it's done now 12 hours apart, so you're checking it at 9 a.m., you're checking it at 9 p.m., and you're seeing how fast those levels are rising. And it will rise as the infant gets older, you just don't want it to be rising so fast that it's going to cause an issue. So there's two types of jaundice or hyperbilirubinemia. So there's physiological, which we're talking about. So elevated bilirubin, which is evident between the 2nd and 4th day of life. It's normal because they have an accelerated destruction of those fetal red blood cells. The fetal red blood cells have a shorter lifespan than adult red blood cells. They can't really conjugate or turn that bilirubin into a type of bilirubin that they can excrete. They have increased bilirubin reabsorption from the intestinal tract, and because of ecchymosis or bruising, they're all reasons that you might see physiological jaundice. So treatment would include phototherapy. That helps to oxidize the bilirubin so it can be excreted in stool. So it's important to know if you have a baby that's under phototherapy to keep them hydrated so they can pee, they can poop, they can get rid of that bilirubin out of their system. BiliTool is based on the American Academy of Pediatric recommendations, and that's a tool that shows us, okay, this baby is so many hours old, this is their bilirubin level, do they need to be treated with phototherapy? Do they need to be, checked again in 2 hours? Do they need to have a serum bilirubin? It depends on the tool what your interventions are going to be. For pathological jaundice, that's an elevated bilirubin that's evident within 24 hours of life. So physiological, meaning we expect it, it's part of the physiological adaptation of a normal newborn. Pathological, meaning something that we're not expecting. There's some kind of disease process happening. So if you see a baby that looks jaundice or looks yellow, skin looks yellow, or looks ruddy, or the sclera of the eyes look yellow, and the baby's not even 24 hours old, then we're thinking there's an abnormal pathological event happening. There's an underlying condition, usually of RH or ABO incompatibility. So you have an RH negative mom with a positive infant, or you have a type O mom with a baby that has type A or B. So again, we care about high levels of bilirubin because they're toxic to the nervous system, can lead to something called kernicterus, which is permanent. And treatment would include early phototherapy. Again, it oxidizes the bilirubin so it can be excreted. If it were to go so far as, you had super high levels, or they were rising at a rate where you needed an exchange transfusion, that infant would get an exchange transfusion of O negative blood. Very rare, but that is something that can happen. And again, they're using the BiliTool, and that's based on the American Academy of Pediatric recommendations. So blood incompatibility, just to go over that again, RH and ABO can cause something called hemolytic disease of the newborn, so fast breakdown of those red blood cells. So an RH negative mother with an RH positive infant, antibodies are produced by the mother from prior exposure. So she has to be exposed to RH positive blood. So that's why we give moms RhoGAM at 28 weeks, and again, if the baby is positive within 72 hours, because that's teaching her body not to make permanent antibodies and not to remember this, these antibodies, so the next time she's pregnant, she's not going to attack that pregnancy and treat it as an infection like a normal healthy immune system would. So what happens if she doesn't get RhoGAM, or if there is this incompatibility, it can result in hemolysis of the fetal red blood cells, so the breakdown of those red blood cells. The fetus compensates by increasing the production of red blood cells, called erythroblasts, and destroys the other blood cells. So what you'll see is an increase in bilirubin. You might see anemia, ascites, because that liver can't quite break those red blood cells down. You'll see jaundice in the first 24 hours, and then you could possibly see enlarged liver or spleen. Treatment would be phototherapy, or again, that blood transfusion of O-negative blood. But in general, in our country, in places with access, you can prevent this with RhoGAM. So mom gets RhoGAM at 28 weeks. She gets RhoGAM again within 72 hours if the baby is positive. That blood product is teaching her body not to make those permanent antibodies, and remember that should she become pregnant again with an RH positive infant. And ABO incompatibility, so both of these incompatibilities can cause hemolytic disease of the newborn, or hyperbilirubinemia. ABO is when the mom or maternal patient is type O and the infant is A or B. So you don't have to be exposed to A or B blood to have anti-A and anti-B antibodies in your serum. That already happens in people that have type O blood. So they can coat the red blood cells of the fetus in utero. It occurs more frequently than RH incompatibilities, again, because we have RhoGAM available. It is less severely clinical than RH if you do see it, and there's nothing that you can do to prevent it. So again, the clinical characteristics are going to be similar. You're going to see jaundice in the first 24 hours, anemia but not as severe, enlarged liver and enlarged spleen could be noted. Treatment is going to be phototherapy. Transfusions are rare. So this is more common, less severe, less common, more severe, but both of them can cause hyperbilirubinemia, hemolytic disease of the newborn, manifested with jaundice and several other complications. You're going to treat it with phototherapy to help break down those red blood cells, to help oxidize that bilirubin and help the baby excrete it through its urine and through its stool. So treatment, like I said, is special lights to reduce the bilirubin levels. They help break down bilirubin, which enables the liver to process them more easily. Bilirubin is excreted in urine and stool, so for nursing care, it's important for you guys to know, you want to protect the eyes and the genitals. You want to keep your infant hydrated for elimination, and you want to monitor those serum bilirubin levels to make sure that they are going down as indicated. So checking your knowledge, you're providing care to a newborn during the first 24 hours of life. Again, all nursing is it normal? Is it not normal? What do I do to intervene? Did what I do to intervene help, or did it not help? So which is an abnormal finding? So respiratory rate of 58 breaths per minute, that's good, because we want 30 to 60, right? Heart rate of 140 beats per minute, good, because we want 110 to 160. Presence of meconium stool, that's the first poop of the baby, totally fine. We want to see that. Yellowing of the skin, not normal. So during the first 24 hours of life, yellowing of the skin is not normal. So that's caused by pathological jaundice. So, something's been happening. Those fetal red blood cells have already been coated, in utero. It's manifesting as, yellowing of the skin before 24 hours. That's usually going to require phototherapy. So all these other assessments are considered normal. So when you're being asked questions, it's very important for you to understand what's normal, what's abnormal, and then if it's abnormal, what then do I do about it? So here's just an explanation, what's normal, what's not normal.